Good morning, everyone. It's dot 11 o'clock and we will start in time. This instruction course or symposium is relevant for all the practicing eye surgeons and entitled where the market today is flooded with so many anti-VEGF agents that it sometimes becomes difficult to choose. So I have with me a galaxy of speakers which include Dr. Mallika Goel, Dr. Dinesh, Dr. Ashish and Dr. Avninder Gupta, who will deliberate, dissect, discuss and maybe come out with some recommendations.
Could you adjust the mic for him, please?
What's that?
आवाज नहीं आ रही.
आवाज आ रही है? Can you hear or not? Yeah, it's here. So all of us will try to discuss, deliberate, and try to put across some messages that common diseases like DME, AMD, how should those be treated? What should be the agents of choice and why? Biosimilars have entered a big way. Newer molecules have also come which promise a larger duration of action. So I'll just give a brief overview for 3-4 minutes. You see, long time back, Michelson identified one factor X which existed in retina that controlled the development of new vessels. And this was nothing but VEGF. And VEGF, Napoleon Ferreira, way back, he actually was a gynecologist who worked as a researcher in Genentech. He and his colleagues were the first to isolate VEGF. VEGF, we all understand, it's produced by the body and it's necessary for normal physiological processes also. But it's also involved in a lot of pathological processes like development of blood supply in tumors, formation of new vessels in ARMD and so on and so forth. So VEGF, remember, is required for some physiological processes, but if in excess, it can, play havoc. So hence the role came of anti-VEGF agents to help in the angiogenesis as well as permeability issues. And anti-VEGF agents, Philip Rosenfield is credited with primarily work on Avastin actually. But since then, there has been actually a reign of anti-VEGFs. And we are lucky to be living in an era where today we have options today, we have choices today. You see on the left side, I have tried to put in anti-VEGF agents, which I call them as first generation anti-VEGFs. You see, Macugen was the first one to get an FDA clearance, but no longer used because the efficacy was not very high. It only slowed down. It never had a graph going up from visual acuity point of view. Then Avastin off-label is in practice by a lot of people and is still the commonest drug used in the US by more than 60% US ophthalmologists. Lucentis, thanks to that Marina Anchor trial long time back, gained a lot of popularity and now we have biosimilars also. Eylea has gained eminence primarily because of, because of that protocol T study. It showed eminence, efficacy above the Avastin, above Lucentis also. On the right side, I have listed drugs which are so-called second generation anti-VEGF agents, where the promise of longer duration is there. Brolucimab, then faricimab came in January of this year only. Aflibercept HD or 8 milligram is although approved but not yet available in India. Then whole lot of biosimilars have entered, not only in India, but in US also. A lot of biosimilars of ranibizumab have been approved for usage. So all these agents just work for two processes primarily. One is permeability issue, other is the new vessel. Faricimab also promises some vascular stability also from the point of view of scarring that may be important. So anti-VEGFs today, believe me, have revolutionized and it is right in front of our eyes. For last 2 decades, all of us have had experience to treat a plethora of ocular angiogenic processes and has a favored treatment for wet AMD, IPCV And since the time, PDT has become unavailable, the monotherapy with anti-VEGFs is the treatment of choice today. Then DME or even DR, even diabetic retinopathy, these severity scales people have studied, RVOs, myopic CNVMs, even ROP. So they have become a boon for retinal disease and is the first line of management in a lot of these diseases. As I said, Macugen or Pegaptanib came in 2004, but it didn't see the light of the day because it didn't improve vision. And today the market is flooded with number of anti-VEGFs, as I showed. And in a whole lot of conditions, they are the first line of management also. So as I said, I would like to divide based on duration of action, bevacizumab, ranibizumab on the left side, and these are the years of FDA approval. And lucky to have the second generation also, brolucimab, faricimab, and aflibercept. You see, RCTs have proven the efficacy and safety of all these molecules. But remember, anti-VEGF treatment is not a one-time treatment that you give one injection. Therefore, counseling has a very important role to play. And you have to spend time with the patient, what should patient expect, and what, the cost issues also you can discuss. Therefore, repeated injections are required, and because of this repetition, sometimes, compliance becomes poor. And we have to ensure, because as of today, this is the only treatment for these conditions. And to ensure compliance, I think you need to enter into dialogue with the patient, but what should he be expecting? Then jumped in biosimilars. The advantage of biosimilars was not only comparable cost, safety, duration, but cost effectiveness, because all these innovator molecules they have some limited period for which the patent is there. After that, it's open to the market for production by other laboratories also. And biosimilars, India is proud to say India was the first country to introduce biosimilar of ranibizumab long time back. This was done by Intas, and subsequently a lot of trade names are available, which are listed here, 1, 2, 3, 4, 5, 6, 7. So many are available. And all of them want their pie, and, there's a tough competition from the point of view of rates of these biosimilars. And even FDA, there are this BioViz and Crimelari, which have been approved in US also. As I said that, the patent for these innovator molecules is limited, and the patent for Lucentis expired some time back, and Eylea is likely to expire this year. So a lot of competition again is, a lot of companies are manufacturing, have started putting their brain behind it, doing trials for Eylea biosimilar also, and soon we'll have that. As far as safety, because safety is of paramount concern in all these conditions. As far as these biosimilars are concerned, all of them had their, even Razumab had that tough time initially, but now Razumab, everybody is using right, left, and center. And they're pretty safe. All of them are approved drugs. And these biosimilars have the potential to at least, make some dent in Avastin usage, because Avastin is not FDA approved, whereas all these biosimilars are FDA approved. So by chance, if something happens, if you have used an FDA approved molecule, you can't be, sued in the court of law. So with this, I'll, close my presentation of this brief overview, and will request Dr. Mallika Goyal regarding her experience of usage of these anti-VEGFs in DME. Thank you so much.
Good morning, everyone. I'd like to thank Dr. Verma for this opportunity. So I'll be speaking upon the broad principles of diabetic macular edema management with anti-VEGFs. It's not playing. Okay. So the principles of DME therapy, primarily first to address is metabolic control of the patient. Look at these, investigate, address these, and then start local treatment, which is primarily serial anti-VEGF injections, which are the first line ocular therapy. Laser, steroid, intravitreal steroids, and vitrectomy have secondary roles in particular cases. So what is metabolic control? It's control of these 5 main factors: glucose, blood pressure, serum lipids, anemia, and renal status. And if these are addressed, improvement can be seen as early as 4 to 6 weeks, even without injections. At the same time, if the edema is significant, the local treatment also starts. DME can be center involving or non-center involving. In the center involving, if the vision is not affected, patient is asymptomatic, and the edema is not severe, foveal contour is nearly normal, you can just observe. If the vision is poorer than 20/32 and the edema is significant, only then injections should be started. For non-center involving DME, there is no role for injections and only laser can be offered. So this is the whole host of anti-VEGF injections and the 2 steroids that are available. The anti-VEGFs remain the first line of therapy as per American, European, Asian Retina Society guidelines for DME management. They not only take care of the macular edema, but they also reduce the diabetic retinopathy severity score so that they take care of the proliferative aspect. Steroids can also be used, but the problem is the raised IOP in a large proportion of patients, cataract in phakic patients, anterior migration if there is a large PC opening, and increased risk of infections in the immunocompromised, which diabetics are immunocompromised. Other limitation of intravitreal steroids, which is not much spoken about, is they are not as good in their visual and anatomical efficacy compared to the newer anti-VEGFs, which was already listed, aflibercept or faricimab. Even when the anatomic response can be similar, the visual result is often inferior to the newer anti-VEGFs, which I have repeatedly seen that even if there is an anatomic response, you can see the vision has actually deteriorated. Now, this has been commented on in many papers, but the reason for this is not really known. However, the patient is definitely more satisfied after an anti-VEGF compared to a steroid injection. So these were the studies in 2008 which showed that there could be more than 10-letter gain with monthly injections of ranibizumab. And then came the VISTA and VIVID in 2015, which showed that instead of monthly, you could give once in 2 months aflibercept injections, and that is as effective as giving it monthly. So that reduced the treatment burden. Now, what is the current guideline on management of mild edema where the vision is good, patient is asymptomatic? Nothing should be done. When aflibercept with laser and observation, these 3 were compared, there was no difference in outcome at 2 years. So if we start treating these patients, we have been over-treating. Just review them periodically and treat if there is a worsening. So this is how now we treat, no intervention, and the patient has resolved spontaneously in 2 years. Once we decide to treat because vision is poor, then the protocol is to give 6 monthly anti-VEGF injections, and at the 6th month, offer laser for the persistent edema. Now, how long should you continue the injections? The injections can continue if there is any improvement compared to the last 2 injections, stop if it remains stable over the last 2 injections, and restart if there is any worsening compared to the last 2 injections. But please note that presence of fluid is not an indication for continuing injections. Now, worsening or improvement means 5-letter change or a 10% central subfield thickness change on OCT. Now, why 6 injections and not just 3 injections? Because at 3 injections, 52% of the eyes still have persistent edema, whereas by the 6th injection, this number has reduced to 32%. Now, which anti-VEGF to choose? In the overall group of patients, all anti-VEGFs, aflibercept and ranibizumab, were similar. But when the vision is lower than 20/50, which means severe diabetic macular edema, at 1 year time, aflibercept gave a speedier and significantly better, statistically more significant improvement in vision. But by 2 years, the difference between aflibercept and ranibizumab was not statistically significant, even though it was, aflibercept still had better visual gain. And the aflibercept continued to remain superior to bevacizumab at all time points. How promptly should the treatment start? Treatment should not be delayed for months to years, because when there is a prompt treatment was given, it was seen there was an 11 letters gain with all ranibizumab or with aflibercept. But when there is a 2-year delay, despite monthly injections, the gain is only 4.5 letters. So prompt treatment is important to prevent permanent damage. Role of macular laser, the drcr.net confirms that laser is very effective. it causes improvement beyond 16 weeks without any additional injections. And there is no difference whether it is done promptly at the first presentation or as a deferred treatment after 6 months. Now, what was it is offered for persistent DME at 6 months of anti-VEGF after 6 months. And what is the percentage of eyes that require laser? With aflibercept, only 41% have persistent DME, whereas with Avastin, 64%, and ranibizumab is intermediate. Additional lasers can be done if required. Fluorescein angiogram to identify the microaneurysms and treat these. Most of the injections are required only in the first year, and almost no injections are required after the third year. Hard exudates are more damaging and also more difficult to take care of. You can see they can progress very rapidly within a month. So these need more intensive treatment. This was a patient where it started resolving with an aflibercept, but patient was lost to follow-up for a few months, came back with significant increase. Again, we were able to treat her and get her to very minimal exudates. But again started increasing because her lipids were very high and diabetes became uncontrolled. So both the things are important, metabolic control and injections. So finally we were able to get down everything. So this is to show that anti-VEGFs work very well for hard exudates. You don't need steroids for hard exudates, and also metabolic control is also enough. There is no injection given in this patient, but the inferonasal exudates have resolved. So metabolic and lipid control are crucial for hard exudates. Injections are not effective if this is not taken care of. Newer potent anti-VEGF agents are effective for hard exudates without the adverse effect of steroids, and steroid is not default therapy for hard exudates. Exudates and edema may respond differently, and they don't always happen simultaneously. Though exudates may need more intensive therapy with injections initially, and long treatment intervals can allow progression, and close follow-up is required initially to monitor for recurrence. Peripheral laser to non-perfusion areas is being found to be not effective for the management of DME. Even post-vitrectomy, the newer anti-VEGFs, at least aflibercept, has been studied, and it has an equally good effect as if it's a non-vitrectomized eye. Post-vitrectomy, when we give steroid for the DME, there is a steroid response sometimes, and then when you switch to aflibercept, I found that there was no difference in efficacy and duration of action. An important concept in DME can be that if you have treated one eye, the other eye can respond very well. So always check the other eye before you give an injection in the other eye after a few days. Sometimes it's not necessary because of the systemic absorption. So when to consider steroids? When anti-VEGF is contraindicated, as in pregnancy, recent cardiovascular events, renal dysfunction, and when there is a traction with active neovascularization, which can get worse with anti-VEGF. But steroids has to be avoided even in those situations in the presence of glaucoma, immunocompromised patient, posterior capsule is absent. And lastly, what is the role of topical NSAID drops for the management of DME? It was found in the drcr.net to not have any significant change in vision, anatomy, or progression to center involving DME compared to sham. Thank you.
Thank you, Malika, for this very, very crisp kind of presentation. We will have, after every talk, 5-minute discussion, because I don't believe that discussion at the end is relevant. So anybody would treat differently than what Dr. Malika has said about because only thing which I could gather was she is dead against steroids. She does
Sorry,
not use...
I could not get your question, sir.
No question, but just a comment. I was just asking the delegates and the learned people sitting here that anybody would do differently than what Malika has presented. Yes, sir.
Hi, Dr. Rahman, great presentation. So you have mentioned that you should be seeing the contralateral eye as well, after seeing one injection. So, what is the evidence that we have for that? How often do you do that? Because for me, we published one paper on the contralateral effect of Ozurdex long back, but I think we were wrong in that sense, because the systemic exit is too low to give any kind of impact on the other eye. That's what I feel. So that's the reason that DME say that bilateral therapy is needed. So I just wanted to have more clarity on that.
No, you're right. Bilateral therapy is needed, and we give most often. But there are those occasional surprises where if you have spaced the two eyes by 5 days or 7 days, or even 10 days, and then you just do a screening of the scan before you treat the second eye, you find that that has also resolved significantly. Patient has improved significantly and is no longer interested in the injection. And probably you don't want to give even because the vision is 6/9, 6/6. So you may not want to give. You can wait. You can defer.
Do you think that has a more relationship with the systemic parameters? Which
No, I don't think so. In 5 days, I don't think so. 5 days will not make.
So no,
think it's
these
an
have been-
anecdotal
some
effect,
observation
which-
has been there. Some
So
observation,
it's just
few
good to
reports are
keep it
there,
in mind.
but to call it, it's not a very common finding, not a very common observation that other eye. If it's a month issue, then what Ashish said is okay. But 5-7 days of observation, if it shows, what is the mechanism? Do you think that systemic absorption and then coming into the eye?
Yes, yes. And that is how systemic absorption is definitely there enough to cause
Side effects.
kidney, renal injury, cause cardiovascular events. So how can it not affect the other eye?
Actually, another proposed mechanism is transchiasmal flow. Part of the transchiasmal flow also. So but it's anecdotal. It's not proved as a regular this thing.
Absolutely.
At the same time, supposing a patient says, I've become better,
Yes.
before you inject, you might as well
You
check
must-
him out.
Yes.
That's all. I mean, it's just, you don't need it in every patient, but in a patient who says, I've become better in my other eye, before you inject him in that eye, check it out.
Yes, sir.
I have a more practical question. Most of the time, the diabetic patients have uncontrolled diabetes. So, do you defer the injections? Do you have a cutoff margin for diabetic patients that in this point I will not give injection in this diabetic status, or any guideline?
So my take on this is both have to go parallel with each other. Unless there are, a lot of heart exudates there, which Malika said, I would not like to wait because Malika said prompt treatment, delayed treatment. Delayed treatment graph still picks up, but it never matches that original this thing. So both can go because diabetes is a lifelong disease. You have to, virtually threaten the patient if you don't control. What is the purpose of giving injection? I tell them, I will give injection. If you don't control, you will have multiple injections all through your life. Although statistically, Malika said maximum injection is required in first year, and then third year it virtually comes down to 1 or 2. But ultimately, metabolic control is what is important in
But
all
Lalit,
this.
it's an important question from the point of view of medical-legal aspects, that when do you not give the injection?
Yeah, we are coming to that. I have not yet finished. So what I'm saying is, although the Government of India guidelines, the court of law, these judges and all, they will not understand. You go to American Academy and European people, I have questioned them also. They don't bother. Even if you see the studies, HbA1c till 12. Even if blood sugar, I have questioned directly to them, same question which you are asking today me. I asked them, even if blood sugar is 400, they will not defer injection. Because blood sugar, you give insulin, it will come down. Immediately you give increase insulin to say 40, 60, it will come down. So you can be safe. But I am not denying that metabolic control has no relevance. It is of utmost importance. But a couple of days here and there you can delay, but you can't defer it for months. Yes.
So in the presence of PCR, you are saying in pseudophakic patients, do you think Ozurdex is absolutely contraindicated, or if you will give in a slightly different way, or just make sure that it doesn't come out into the anterior chamber?
Yeah, if there's a very large opening, let's say scleral fixated IOLs are there where there is no PC at all, or FAK if at all. Well, I have seen it in a scleral fixated IOL where it has migrated and caused a corneal emergency, raised IOP, and then we had to remove it in emergency. So it is a contraindication. It's even in the package insert it is given, not to use it where there is an absent PC or a large opening. So you could even have medical-legal problems, in fact, because it's there in the package insert. So be careful. Be careful.
Fixated IOLs are different. Suppose routine pseudofakes, they have some PCR.
No, not that. Not a regular PC opening, but an large one, unusually large one.
Any other observation or comment? Otherwise, we move on to Dinesh Talwar about his choice and protocol in the management of wet AMD.
Go ahead. Good morning, ladies and gentlemen. Thank you, Lalit. After diabetes, in terms of numbers in this country, I think age-related macular degeneration is the next important disease. This is my disclaimer and my financial disclosure. Now, exudative ARMD is not a single disease. You have CNVs due to predominantly classic lesions, minimally classic lesions, occult lesions, various types of occult lesions, and these different patients behave differently, though that's not stressed upon adequately. The Marina and Anchor study showed us very clearly that sustained visual acuity gains were possible with monthly ranibizumab, and those could be maintained for a long time, and the gold standard for that was a monthly regime till recently. But the unfortunate thing is that that's an extremely intensive and exhausting regime, both for the patient and the doctor. The sustained study also showed us that while you need monthly treatment for many, but there is a need to individualize treatment, and there are almost 20% of patients who only need around the loading dose of 3 injections, don't need any more. And at the same time, there's the other end of the spectrum who need injections virtually monthly. Today, we have a lot of choices. We have ranibizumab in different forms, we have bevacizumab, we have aflibercept, we have brolucizumab, and we have faricimab. So how do we manage today? Well, not only do we have different drugs, we also have different regimes for treatment. Starting with the monthly one, we now have 2 monthly, quarterly, PRN, and treat and extend regimes, which have all found utility. How to decide for an individual patient? What is the optimal treatment? That depends on efficacy, safety, ease of use for the patient and doctor, and the intervals that you can maintain between the treatments. The Sailor study showed us very clearly that if your monitoring is every 3 months, that is grossly inadequate. The gains in the first 3 months are lost by the end of the year. And a simple change, monitoring monthly, treating 3 monthly, even that changed the results and gave more sustained visual gains in the sustained study. So what we learned from these studies was that if you're monitoring, it should be monthly. There are very stringent guidelines for retreatment, including minimal change in BCVA, any evidence of fluid, increase in the central retinal thickness, any new hemorrhage. So their fundus examination is also extremely important. Now, the latest regime to be used, which is found to be most safe, is the treat and extend regime, where you slowly extend the duration between treatments, and you decrease that duration if you find any recurrences. The Altair study made it even a little more strict. It shortened the interval only for any persistent fluid as well as increasing fluid. It only maintained the interval between injections if the fluid was decreasing, and extended the interval only when there was a dry lesion. So I believe that possibly the best option for patients who are one-eyed or those who become stable but are not drying completely is a treat and extend regime. On the other hand, most of the two-eyed patients who have complete drying of the lesion are probably the best treated by a PRN regime with what we call a monitor and extend. That means you monitor, they stay dry for 6 months, and you can then extend the intervals between the follow-ups. Which drug is optimal? Well, for me, even today, for type C NVMs, I find ranibizumab is extremely effective, and that's my first-line drug. For type 1 CNVMs, I believe aflibercept is better than ranibizumab, and that is my drug of choice. Now, if you don't have access to anything else, remember monthly bevacizumab also is almost as good as monthly ranibizumab, though the macula dries less quickly and less often. Brolucizumab is probably more effective in drying the fluid, any types of fluid, but with faricimab, you can maintain even longer intervals than 12 weeks in the majority of your patients. As far as safety is concerned, both ranibizumab and aflibercept are safe. With bevacizumab, we've had episodes of cluster endophthalmitis. Not the drug per se is safe. Brolucizumab does carry an additional risk of intraocular inflammation and a small risk of inflammatory vascular occlusions. In case of a systemic problem, recent MI, recent stroke, the only safe drug for you, which is validated, is ranibizumab 0.3 milligrams. How much can we increase the interval between these treatments? Well, the fluid study showed us 7 weeks for ranibizumab, brolucizumab up to 12 weeks in more than 50%. The Altair study showed us that aflibercept, you could go to an extension of 12 weekly within 60% of patients, and up to 16 weeks in 40% of them. And finally, with faricimab, greater than 12 weekly extensions are possible in over 80% of patients. Today, the workhorse of management in AMD is actually aflibercept. How do I actually manage my patient? So you give the 3 loading doses, and loading doses are necessary in AMD. At the end of 3 injections, 1 month later, if the lesion is dry, as I said, if it's a one-eyed patient, I would put into a treat and extend regime. If it's dry, I will monitor for the next 3 months, every month. If recurrence occurs, I treat it if it does, on a PRN basis. If it doesn't occur, I increase the monitoring intervals from 4 weeks to 6 weeks to 8 weeks, and finally up to 12 weeks if the patient stays dry. In patients who need ranibizumab more than 8 weekly, say 6 weekly, 4 weekly, those patients should be considered for PRN aflibercept. Now, but a large proportion of patients don't dry at the end of 3 months. They still have some fluid. So these patients you give for the next 3 months, every month injections. If they dry, now the algorithm for them becomes what I told you before in case the patient becomes dry. In case it doesn't become dry, you will find that finally the amount of fluid becomes stable. If the cysts are there, they remain the same. If subretinal fluid is there, that remains the same. And these patients now you can put into a treat and extend regime, increasing the duration between the injections till you reach at least 12 weeks with ranibizumab or up to 16 weeks with aflibercept. In patients with occult lesions who have stable but not dry lesions after the loading dose of aflibercept, I will try a treat and extend regime, and if I can go beyond 8 weeks, I will continue that. If I can't do that, I will switch to either brolucizumab or faricimab. When do I switch? To switch, if you have a patient who's on ranibizumab and he's getting a recurrence every 7 weeks or less, or is stable and I can't extend him beyond 7 weeks, I will consider a switch to aflibercept. A patient who's on aflibercept and I can't increase the durations beyond 7 weeks, I will consider a switch to brolucizumab or faricimab. And if the patient has received a brolucizumab, now he's not completely dry at 4 weeks. I don't want to give the next injection 4 weekly. I try to delay at least to 8 weeks. So in between, I will give 1 injection of aflibercept. This is just to show a patient who was on Eylea. The patient had received the injections every month for almost 16 months, was still not drying off. And then we gave him a brolucizumab. There was no change a day later. 1 week later, there was some decrease in the lesion. By 4 weeks, there was still some cyst left. I gave him an aflibercept. He did not dry further, and then brolucizumab was repeated, and there was almost complete drying of this lesion. So this patient, after that, has been on 3 monthly brolucizumab. But the important message here, it's not brolucizumab or ranibizumab or aflibercept. A long-term outcome done in with a treatment and extend regime with all these 3 drugs revealed, no difference in visual acuity outcomes or number of injections over a long term. And what did it show? The number of injections was not same. The fluid was also the same. And most importantly, what worked? Eyes that got more injections did better. Eyes that had treatment for a longer period did better. So ultimately, what is more important is the number of injections, the more the time till injections are continued. And that gives the best outcomes. In fact, there's another study called the FIDO study, which gave fixed interval dosing of 4 to 8 weekly. And for 7 years, at 7 years, they maintained better than 612 vision in more than 40% of patients, and more than 618 vision in 2/3 of the patient. So even the most important thing, the message, don't stop the drug. What is more important is giving the treatment, not particularly running after one drug or the other. Ladies and gentlemen, the basic principles, there are 2 principles. One group tolerates no fluid, the other tolerates some. We do not tolerate fluid. We do not like to tolerate intraretinal fluid. We don't like to tolerate subretinal fluid unless it's completely unresponsive to treatment. For sub-RPE fluid, don't run after it. It doesn't go with ranibizumab, partially goes with aflibercept, and even with the other drugs, it may not go fully. But you're not treating sub-RPE fluid. You are treating only the intraretinal and subretinal fluid as a routine, and that's it. Ladies and gentlemen, what we've learned over this period is that aggressive monitoring is the key. And this monitoring is needed up to lifelong in a patient, even after he becomes dry. greater the number of injections, more intensive and longer the follow-up, better the visual outcomes. Initial PRN treatment gives you the guide to change the patient to a treat and extend regime later on. But the most important thing is have a high index of suspicion for retreatment, and eternal vigil is the price you pay for vision in patients with CNV. Thank you very much, ladies and gentlemen.
Thank you, Dinesh, for this crystal clear messages. Couple of them I may like to repeat, even at the cost of repetition, is in contrast to diabetes, where the message here was don't stop in ARMD, because ARMD is different disease than diabetes. Second was this, because fluid theory conveyed different messages, that SRF is tolerable, and some people also said that SRF fluid may have better vision also. But this is not acceptable because there are now better drying agents available. The other thing which, Dinesh, I wanted a small comment was that in your case, which you showed aflibercept, not responsive, then switch to brolucimab, then again come back to aflibercept, if not then brolucimab. Why this lassi?
Okay, so the basic, you know that with brolucizumab it's been repeated that you should not be giving the injection every 4 weeks. You should try to increase the duration. Now when I have a situation when the patient not responded fully, I don't want to leave the patient with no treatment. So the aflibercept is a stopgap arrangement in this situation. And that just carries on for another month, then you repeat the brolucizumab. And in this patient, after we gave the brolucizumab, became dry for the next time, and then stayed dry for 3 months before a recurrence occurred.
But ultimately, again, you brought to brolucimab
yes.
for 3 months.
So it's only that if in less than 3 months I need to repeat a drug, I will give aflibercept rather than giving brolucizumab.
Today, with the availability of faricimab, would you consider brolucimab vis-a-vis
So if the
faricimab?
patient now, there are patients who
Because
can't
the
go
reason
for,
I'm
absolutely.
asking is because this newer generation of agents, which
Yes.
promise extended duration,
Yes.
and with the faricimab saying 3 Ds, duration, durability, and dual mechanism of action, will you consider brolucimab in a patient who is not responsive to aflibercept or faricimab?
Yes, today you're right, Lalit. I would actually prefer to give faricimab, but these are early days for me with faricimab. I've only given a few injections. I have had early responses also, but I don't have a 2-month follow-up to see how long the it stays. But yes, I would like to, instead of brolucizumab, give faricimab if the patient can afford it.
So one last question before we ask Ashish to come is that if you believe that faricimab in your initial experience also is working in resistant patients, so why not throw away aflibercept and start on faricimab?
Yeah. You see, whenever anything new comes, you want to first test it out. And the best way to test it out is in the worst patients. The reason is that if something works in the worst patients, then I'm sure it'll work in the good
No,
patients
this is
also.
acceptable. This is acceptable. You see,
No,
obviously,
no, I'm saying this is why maybe tomorrow, maybe after 6 months, if you ask me, I will shift to faricimab.
Yeah,
but as of today, that's not my drug of choice.
Okay. We presume that based on the data of Tanya, Lucerne, whatever is available, because though there has been PRCT done and you have to pay weightage to that data also.
Yes.
That data is not, has been approved by FDA. So I am happy to say that you will consider giving faricimab as first-line agent also.
Yes, but remember, it's then it will become an economic decision because
I'm coming to economic.
Yeah.
Last question, economic also, because economy, I will cover economically. If you consider the yearly treatment, because duration, if faricimab after the loading dose, if it is maintained on even 10 or 12 weeks, yearly cost becomes less.
Exactly. So basically, I expect that 70 to 80% of patients on faricimab, we will be able to shift to 12 weekly injection. If the cost of a 12 weekly injection, if it turns out that this fact is true, and the cost of the 12 full year's injection is cheaper with faricimab, I will ask the patient to shift.
Okay, thanks Dinesh for some clarification. But remember, one point I still would make here, that out of all the second generation and first generation anti-VEGFs, there's nothing to compare brolucimab drying capacity.
It's early days. I don't know yet.
No, whatever data I have of brolucimab, I think
One component.
yeah. So brolucimab ki drying na wo unmatchable hai. is not, I'm not saying that all patients statistically, but capacity of brolucizumab, maybe because of smaller molecule and high molar mass, capacity is actually...
Okay, so my experience with brolucizumab...
There is a fear of IUI, there's no doubt.
No, I guess one thing I want to say, my experience with brolucizumab is only in intractable cases. Those who have not responded to multiple doses of aflibercept. And let me just tell you, the figure is not the same as general treatment. The figure is 1/3 complete resolution for 3 months. 1/3 partial resolution requires injections more than 3 months. And 1/3 no response.
Dinesh, the question is, there is a huge amount of data of brolucizumab available, huge, thousands of patient data available in the country, in this country. Your data may be, say, a few patients.
That's
me,
treatment naive.
But believe me, there are patients available. There's no question about it that the drying of brolucizumab is much superior.
One patient of mine with brolucizumab, I'm giving every 5 weekly. And I have given somewhere around 22 injections in that patient.
More than 30 injections have been given.
And that patient didn't show any response. What you commented, you should not give before 6 weeks. But I'm regularly giving, and it's patient comes and tell me my vision has gone down.
Every 6 weeks.
Yeah.
This is exactly the point I'm trying to make.
Weekly injections
that despite the data which is shown over there, it's not every 12 weeks. Many patients are every 6 weeks. Even the drying is not total in every patient; it's partial in many patients.
Yeah. But the point to make here was not the efficacy, but the fear of IUI. Maybe it's different than what data we have in India, vis-a-vis what data we have from US. Because this patient I know, because I am also following up this patient, same patient. In a single-eyed patient, left eye, this gentleman, 84-year-old.
Yeah.
84-year-old gentleman has received nearly 30 injections of brolucizumab. Not even a single IUI event has been noted. Having said that, any other comments from the audience regarding presentation by Dinesh? You can, yeah.
What will be your comments about ZIV aflibercept vis-a-vis aflibercept?
Okay, this is a legal issue and it is completely contraindicated. Now, you must understand why. ZIV aflibercept is not the same thing as bevacizumab. Bevacizumab, there is no ocular alternative available, and therefore you can say off-label use. But here you have the ocular drug available. When you have the ocular drug available, and the company says this is for the eye and this is for the rest of the body, now when you use it for the eye, you're putting yourself at risk. And that is totally your risk. It's nothing to do with the patient, nothing to do with the...
We are not talking about the efficacy-wise, but legal issue can be there.
But same was the issue with Avastin and Lucentis.
No, it's not.
Avastin is not available for eye.
No, that's what. Avastin is still being used
What he's saying is,
off-label.
please understand, what he's saying is, aflibercept is available for the eye.
Yes.
This Avastin is not available for the eye.
The molecule has been changed.
Equivalent for bevacizumab.
Okay.
Right?
In any case, we will carry on these questions. Now we have with us Ashish.
I have a question, sir.
Yes, sir. Yes, sir.
Sir, actually, though it is not a formal study, I have seen in many patients that after 3 years, we are continuing the injections. There is no such improvement in many cases. After 3 years of injection, first year 6 injections, then PRN basis. But after 3 years, 13, 14, 15 injections, after 3 years, there is no such improvement.
I think it's a very important point to highlight. You don't expect regular improvement with every injection. Otherwise, human ki aankh cheel ki aankh ban jayegi. ठीक है ना? See, what you have is an initial improvement, then it stabilizes, and then what you want is a plateau. It's not going to improve anymore. After the first 4 or 5 injections, you're not looking in terms of improvement. You're looking in terms of maintenance. And maintenance is in terms of maintaining the quality of that vision. That's all.
Actually, my question is that if we continuing the injections, are we making the retina more ischemic?
No, you're not
After
making
that-
it, but you are increasing.
AMD or DME? Are you talking about AMD or DME?
No, both AMD and DME, both patients.
Okay, so in AMD, you may either uncover an ongoing atrophy, or it may predispose to a greater degree of atrophy. We are not sure yet. with anti-VEGFs. With DME, it doesn't increase the atrophy because overall the RP is fairly normal. So in that terms, it's a choice. That's why I said I give ranibizumab in patients who don't need a more stronger drug. So you want to give the least strong drug to maintain the patient. So if I need aflibercept, I'm only giving it once in 3 months because I don't want to give too many injections. You don't want to give unnecessary treatment.
Okay, I think we will carry on discussion. Let's finish the other.
One question to Dr. Lalit. So you said brolucizumab Indian data is different. So is the inflammation less in Indian patients?
Yeah. Definitely less. There's hardly, because the data published or whatever the label says is around 4.5%. But whatsoever data is available pan-India, in fact, my data of 120 eyes, not even a single eye had inflammation. The only difference is I don't give a loading dose. That's all. I give PRN only. We don't give loading dose of brolucizumab.
Thanks.
Okay, I think we have with us, and very fortunate to have Ashish with us, who is actually the world authority on biosimilars, and he will tell us how have they filled the gap. Or question is, have they filled the gap or not?
So, good afternoon, and rather good morning or good afternoon, ladies and gentlemen. And thank you, Dr. Lalit, for having me here again. And thank you, Dr. Talwar, and thank you, Dr. Mallika, for putting it right across that treatment is required. You cannot stop treatment. So these are the conditions where you need to keep treating these patients again and again. Topic that I'm going to talk about, that whether biosimilars have filled the gap. I'll proceed further. Before that, these are my disclosures. I do have disclosures to various biosimilar companies across the globe. We have been trying to understand biosimilars since last 4 to 5 years in terms of various aspects, like how do you switch, whether switching between biosimilars have any significance, or what kind of phase 3 trials that biosimilars go through, and why there is negative perception about them in the beginning. So this is our contribution in the form of various publications, and I would definitely like to highlight our group across the globe who have been part of all these work that we published in the recent past. So the question is gap, whether biosimilars, they fill the gap. So first question is gap, means what are we talking about here in terms of the gap? So if you really look at Dr. Talwar, what he said in his talk, I give a ranibizumab. He didn't mention that I give Avastin, right? So we have come to a stage where we started talking about that I give ranibizumab. That means ranibizumab has become your primary drug of choice now, which was not there in the past, probably if you talk about 5 years before. So the gap which was there between Avastin and Lucentis, the pricing is approximately 3 to 4 times. So this was the gap which India was looking for, because we are in a different kind of financial system. Our patients are in a different kind of financial system. So this was the big gap which was created and which needed to be filled in. Need. Now let's come to the need, that why you have that gap and from where that gap is created. If you really look at the data, although as a country, we are not really data-driven country, our statistics are not that great compared to West, but still, if you have a nutshell analysis of the diseases where you need biosimilars, or rather anti-VEGF injections, so you have approximately 0.8% of total adult population more than 30 years suffering from RVO, and then you have diabetic population of approximately 7 crore, and out of them 7% have diabetic macular edema, and approximately 16% of Indian population more than 50 years with a prevalence rate of 3.4%, you have a population of more than 1 crore. More than 1 crore patients, they require anti-VEGF injection, and this is not a one-time injection. So you need 1 crore anti-VEGF injections every month. Look at the disease burden. Rather than disease burden, look at the financial burden that our patients have to go through. Even I can talk about, means I'm a middle class person. Even if something goes wrong with my parents, it is difficult to afford this therapy for my parents as well, until unless we have filled that gap. So that is what has happened in India. If you really look at the statistics, what is happening because of non-affordability? You have a huge group of patients who are lost to follow-up. Our average injection rate is approximately 3. And our previous speakers have very well highlighted that that does not work. Until unless we keep treating these patients, I think all of us are retina specialists, and we have seen patients who have been on therapy for a very long time, they have enjoyed vision, they have enjoyed their activities for really, really long time. So now, Dr. Lalit asked me, you speak about whether that gap is being filled up or not. So I lead an international retina biosimilar study group called InterBios Group, where we are trying to understand whether this gap is being filled in India or over the entire globe, different countries. There are few biosimilar powerhouses like South Korea, India, and some countries in Europe as well. So this was an essential survey by the Vitreoretinal Society of India in collaboration with InterBios Group, where we try to understand that what kind of gap was there and what is happening now. Before I proceed further to the findings of this, I have two questions to this wise audience. How many of you have heard about biosimilars? If I can have raise of hands. Thank you. And how many of you have used in your entire practice at some point of time any biosimilar? So probably this is around 50 to 60%. So now let's go to our survey. So this was essentially focused on the retina specialists. So what has happened in the past, in last few years, is that gap of ranibizumab, which is the only biosimilar that you have available now, it has a proportion of 75% usage in majority of practices. And then what happened to the innovator ranibizumab, which is Lucentis? It has shrunk down till less than 25%. Prime reason, financial. It decreases the cost to the patient. Now, all the retina specialists, they agree that it has definitely made therapy affordable, and they would surely like to use this therapy in coming future as well. So the gap is being filled by biosimilars for sure. And as Dr. Talwar said, I was in some other session yesterday also, now people are talking about, I start my treatment with ranibizumab. And I think I would definitely give credit to biosimilar ranibizumab for the same. Otherwise, still, if these molecules wouldn't been there, Lucentis pricing would have been staying there. We would have been having this gap. We would have been using Avastin more and more. We would be seeing this financial gap, and we would have been having all these dropouts. So this has made a major difference. Now the question is this just India? Now biosimilar means, I'm not sure how many of us are aware of, you have biosimilar ranibizumab across the globe now. Europe has it, UK has it. So there are two major molecules which are available. One is Cimerli, one is from Biogen. Cimerli was the first molecule that has received interchangeability approval by the FDA, which was first time in the history of FDA that any molecule has received interchangeability approval without any additional trial. Let me explain you what interchangeability means. That means patient comes to you. In US system works in a different way. There is a lot of time doctor does not have that say. Your insurance company defines it. They decide that what this patient has to get. You just write ranibizumab, and then insurance allows, it can immediately at the pharmacy level, it can be substituted. So that is what the interchangeability is. So that is happening. I was in academy last 3 years before when Cimerli was being launched and Biogen product was being launched, where a lot of our colleagues were talking about that we do not see any future of biosimilars in America. Reason behind, because they are quite confident with Avastin because they have compounding pharmacy, robust compounding pharmacies, they can fractionate well. They have no issues with any kind of legality in terms of off-label use, and means they never had troubles with that. But what happened? I was in Retina last year. What has happened in America, you look at the developed world. In the last 2 years, biosimilar ranibizumab has crossed the usage of Lucentis in United States of America as well. So it is not only us. We are financially compromised in a different way. Our patients are financially compromised, but countries like America, Europe, they are financially compromised in a different way, where insurance drives to have cheaper drugs so that they can put that money somewhere else in the patient care. So this is the paper that we recently published, because whenever I speak about biosimilars, a lot of questions come in that can I use this one, can I use this one, this is from where. So in a nutshell, in India as of now, in use, you have 3 manufacturers who really manufacture these drugs. Razumab from Intas Pharmaceutical, with the highest real-world data, they market themselves. So Razumab is from Intas. Now another drug, Ranizorel, which came after Razumab, it is manufactured by Reliance, and it is marketed by Cipla as well under the name of Vizumab. Renice, product of Lupin, they manufacture it. It is marketed by Sun Pharma with the name of Osiva. So just remember that original manufacturers and the marketer. Another molecule which came recently had trouble in the between. Patient means product is withdrawn from Engine Biosciences. Optimab, that is a product of Alchem, marketed by different companies, Ipca and Mankind. So now I already explained you the differential. Like what happens, whenever biosimilar comes in, you have different kind of negative perception going on around there. And as a clinician, as a person from scientific community, this is our responsibility that we convey the right information. This was a paper which was recently published in Ophthalmology Retina, Biosimilar Paradox, how anti-VEGF endothelial growth factor biosimilars could increase patient cost and healthcare cost. Such a deviated, such a biased title. By title, you can assess that maybe anti-VEGF might be increasing cost in America. But this was essentially hypothetical. In case on-label bevacizumab approves in America, then Avastin would be banned, and then the cost will increase. We had a strong rebuttal against this, that this should not be conveyed. This causes negative perception to people. So I strongly believe that many lives can become better. They are getting better since we have biosimilars on our practice. And as you have more and more molecules coming in, it is giving a pricing pressure to everybody. Other biosimilar guy, originator guy. So ultimate, at the bottom of the pyramid, beneficiary is your patients. That's what you wanted. So thank you so very much for having me here.
Mike.
About biosimilar aflibercept, what is the possibility of that coming into the market soon?
So, sir, actually, aflibercept biosimilar is ready by many companies. Now, if you must have seen, Mylan was a company which has made, and now the Mylan has been, then it went to Viatris, and Viatris being sold to Biocon. So now, actually, India Biocon has that already approval by the EMA. So, molecule is approved. In between, so what happened if this molecule was approved and it was supposed to be in clinic at the end of the quarter of 2024. But in between, what happened? Regeneron had a case with Viatris, and they won that case on the patent issue. So their proprietary, now it has shifted that we might get it in either at the end of quarter of 2025 or even the first quarter of 2026. But all the companies, approximately 4 molecules are ready.
The other question I'd like to ask you, everyone stresses on the cost of biosimilars. What about the cost of administering biosimilars? Because I believe actually, and in fact,
we will come to the economics.
I think,
cost,
sir,
but
will talk about economics.
There are two talks remaining also. So, Thank you, Ashish, for partly covering what I wanted to cover. You see, today, because Dinesh said it's what you required, lifelong treatment, diabetics burden is so high. Ashish says can't afford treatment for father with innovator molecule, and eccentrics usage dropping down, and insurance-driven market in the US, and biosimilars have actually filled the gap. These are a couple of 5 lines I noted from Ashish's talk. You see, as I started, today we have first generation, second generation, plus these biosimilars. So these molecules got approval based on these studies, which we will not go into details. And as has been stressed again and again, and which Ashish made a very strong statement, it's not one-time treatment. If you call the patient repeatedly, compliance suffers. Once compliance suffers, the benefit of the disease does not happen. So blame may be there. And Dinesh said repeated injections means more response. More the number of injections, more the response. So what do? Real world scenario, believe me, nearly half, 47% patients only have compliance to RCT trials. So ultimately, as Ashish also said, cost is the main factor. Believe me, in US, insurance coverage is very high. In India, we have to strategize because the insurance coverage, patient generally pays from his own pocket. Biosimilars have definitely filled the gap, which Ashish said very nicely. And I will not repeat this because these are the biosimilars, 4 companies and 7 companies marketing also, and FDA approved also in US also. So patent, like Dinesh was talking about FDA, this biosimilar of Eylea of aflibercept also being available within a year. I think it will come here. So this paradigm shift has already happened from innovator to biosimilar. It's already happened, and everybody, a lot of studies have been published on biosimilars regarding their efficacy, safety. This was one from our group which clearly said that this was on Razumab, which we started using long time back. So they are safe, there's no doubt about it. There was initial hiccup when one batch of, I think batch number 5 of Razumab, but after that there has been no looking back at all. In fact, today if you write eccentrics or Razumab, you can be caught. You just have to write ranibizumab, within bracket you may write, because in our center one letter came back from the ministry, how come you have written eccentrics? You cannot. You have to write molecule name, generic name only. So we just analyzed before coming here 1 year data of our center site, and there were a total number of data from 2023, 2018 injections, and cash component is pretty high in this country. Hence comes the cost of affordability. And this is the data which was analyzed by one of our fellows. Eylea still reigns very high because of, I think, multiple schemes which have been launched. 2+3, and recently they have launched one more scheme, 5+9, that becomes 14 injections, which was launched a couple of days back only. And second amongst the ranibizumab, it is the biosimilar which has actually displaced the innovator, like Ashish also showed, to the next level. And amongst the biosimilars, I was working on that. Amongst the biosimilars, because of the longevity they have been in the market, Razumab still reigns very high. With no disregard to other companies, believe me, this is just analysis of data which we did. And more than twice the number of patients opted for biosimilars. You see 588 biosimilars versus nearly less than half of eccentrics. So this is the most sensitive part. In 4 slides, I'll summarize about the economic part, because everybody has been talking, Dinesh touched upon this. There are issues about whatever is the MRP printed and what is the landing cost to the doctor. I am being very blunt here because this may annoy somebody, but it's okay. So these are the various anti-VEGFs we have listed here. This is, believe me, the landing cost which they offer for the medical people. This is landing cost of various molecules. There may be some minor differences here and there. But this is the MRP which has been printed here. Okay. Because of this scheme which eccentrics offers pay to get 3, Eylea offers pay to get 5, the effective cost per injection comes to this. The biosimilars remain the same, but this eccentrics and Eylea, they drop down. This is the effective cost of the injection. So Dinesh was talking about the cost to the patient, because there is an administration cost, OT cost, This I have ranged from 5 to K depending on your stature or depending on the setup you have. So this I have ranged from 5,000 to 10,000. So this is the cost per injection to the patient, which means effective cost plus the admission cost. And I have just taken, for the sake of discussion, these first line molecules as generally 4 weeks interval, and Eylea as Q8, and Pagenex as 3, and Vabysmo as per studies, because we do not have much experience, as either 3 to 4 months, and Ozurdex 3.5, this I am pretty sure about that. And this is the yearly injections, because this I have listed to 50, this is the ideal scenario as per RCTs, that you require 12 injections, or in the first year at least, or 6 injections or 3. But from practical, this last is the real world. This was the ideal, this is the real world. And this is the costing for the patient who requires this injection. So this is a complicated, therefore I started from 1, 2, 3 and 7. So if you see amongst ranibizumab and its biosimilars, there is not much to choose from the cost point of view. If you consider MRP as the price, because most of the doctors will charge MRP plus their cost. And this is coming to nearly the same, maybe actually slightly lower only. And amongst the first generation, which now includes the Eylea also, so Eylea reigns supreme here. You see, the cost is lower than the Eccentrics as well as its biosimilars, primarily because of the scheme. So my topic was scheme and baits, what the companies offer. And this is the copy, I got it today only from one of the soft companies, is this scheme which they have launched now. Eylea is 5 and 14 injections. You pay for 5, get 14. So this is the bait which is being offered by the companies also. So patient will get 14 injections at the cost of 5 injections. Coming to second generation anti-VEGF agents, which promises longer duration, number of visits cost, and reduced cost of imaging. I have not figured in the cost of travel, cost of imaging, consultation cost here, because that will be same in by and large all. So amongst these 3 molecules, which is brolucimab, Vabysmo, is also, the offer is same as Eylea, 2 plus 3, although they say 1 plus 1 and 1 plus 2, but it's practically the same. Believe me, if you consider these costs and they see the durability, maybe, that is the reason I was asking Dinesh, maybe, today maybe Eylea is reigning supreme, but maybe they will make a dent in Eylea also because of the ultimate cost reduction of these molecules. So this is what I wanted to share with you. Comparative cost of newer anti-VEGFs, which promises increased duration, decreased visits, may ultimately become cheaper and may become the preferred mode of treatment because of duration of action itself. Can we consider this? Because Ashish also said, ultimately all of us are accountable to patients first, that patients should ultimately pay less and get the maximum benefit. Thank you very much for your kind attention.
Thank you, Lalit. That's very impressive, and I think that's a very exhaustive study that you've done of the cost involved. And I think it points out that if you can decrease the frequency of the injections, you can bring down the cost very substantially.
So let's hear Avninder first, because he has to complete his talk before discussion. Is because these injections are being given right, left, center by everybody. There's no ban. You have to just be an ophthalmologist to deliver. I personally feel there is more abuse than use of anti-VEGFs. Any macular lesion, people tend to give anti-VEGF. Required, not required, whether it is scar or there is small cyst, people will keep injecting. So we have Avninder Visal who will tell us about abuse only. What is the abuse?
Thank you, sir, for giving me this topic. We have been discussing among ourselves how, where not to use anti-VEGF. I'll say not abuse, misuse of anti-VEGF. Thank you, Dr. Lalit, for having me here. Anti-VEGF is the most widely used pharmacological agent in retina practice. It is considered to be the cure of all retinal pathologies, and that is the basic problem, and hence it is most misused drug. So look at this prescription. Vision of the patient was finger count, and if you look the OCT pictures, near normal foveal contour, vision was finger count. And if you look at this prescription here, injection ranibizumab intravitreal has been advised. I don't know when I asked the patient why it was advised and what was the promise given by the doctor. He said कि काम कर सकता है नहीं भी काम कर सकता है, ये आपकी किस्मत है. When I went into the history, patient was on ATT and he was taking combutol. So I diagnosed this patient as combutol toxicity. So ranibizumab doesn't work in these kind of patient. Now this patient, if you see, there is an intraretinal edema with subretinal fluid here, has received 2 injections and then came to me कि डॉक्टर साहब 2 इंजेक्शन लग गए, कोई फ़ायदा नहीं हो रहा, क्या करें, लगवाएं कि ना लगवाएं. I went ahead and repeated the OCT, and if you can see the OCT here, there is a macular hole here. This patient didn't require anti-VEGF injections, and this patient required surgery. So wrong diagnostic or taking a cut at a wrong place can give you a wrong information, and your treatment changes accordingly. This is a patient of diabetes, right eye 6/9, left eye 6/18 vision, has received multiple injections, came with this kind of picture. You can see DME here. And what the doctor has missed here is in pre-retinal hemorrhage here. So if you have, what is the basic teaching, if you have a pre-retinal hemorrhage, then it becomes a proliferative diabetic retinopathy. And you know, and the problem nowadays here is that the number of fundus cameras are going down. Nobody wants to do a fluorescein angiography. Everyone wants to do an OCT and inject. So nobody did an fluorescein angiography, and you can see once we did an fluorescein angiography, you can see huge areas of capillary non-perfusion and NVE. So you will keep on injecting, this patient will not respond to diabetic macular edema, because here the source of VEGF is these areas of capillary non-perfusion. And if you don't take care of these areas of capillary non-perfusion, macular edema, VEGF secretion will continue. You will give anti-VEGF for a particular period of time. 1 month there will be a benefit. That edema will reoccur again. Many of you will say protocol S suggests that yes, you have to give monthly injections, which gives 4-word letter. But important thing here is patient who do not follow. It's very important to counsel these patients that you should go in for a monthly injection. And those patients who missed the schedule of 1 month and came after 6 months missing the follow-up, these patients landed up with hand movements vision. So it's important that you laser this patient, and we are forgetting this art of lasering the patient in cases of proliferative diabetic retinopathy. This is another patient of proliferative diabetic retinopathy. We know that everyone wants to inject. So if you have this kind of a fibrous proliferation, the surgeon, the physician gave an injection, he didn't have a facility of the surgery. And what he lands up here, what you see, within 3 days, this patient land up with tractional retinal detachment. And you can see whole of this macula is detached. And if you leave this patient at this stage also, patient will come with a combined detachment after 2 to 3 weeks. So you have to intervene this patient. So the message here is, if you have any elevated NVEs, if you have any kind of a fibrous proliferation, and if you are not doing surgery, you are not a vitreoretinal surgeon, please do not inject in these patients, because if you inject, you can land up into a situation like this. And this also stands with vitreous hemorrhage also. Because vitreous hemorrhage, we don't know what is the condition of the retina, and if you have the proliferation like this and you have injected, patient will, you don't know what is going on inside, and patient can land up into a situation what you call as intractional retinal detachment. We took this patient for surgery, and this is post-operative. You can see the macula is well attached, and patient improved to 6/18 vision. We give anti-VEGF, but prior to the surgery, to prevent intraoperative bleeding, not as a therapeutic treatment. Another, this patient, non-dilating pupil, received anti-VEGF 3 months, at 3 months interval, came with NVI and NVG. In my practice, because most of the people are injecting. They are not looking at fluorescein angiographic picture. Patient, when I did angiography of this patient, you can see a total non-ischemia, and this patient had NVI. One eye was lost, had a pressure of 60. I couldn't do anything. I did a good pan-retinal photocoagulation, and I saved the other eye. So please, please don't keep on injecting. Look at the areas of non-perfusion also. This is one of the patients of central serous retinopathy suffering. It's a chronic CSR suffering from last 8 months. 2 injections has been given, no improvement, but the physician didn't do a fluorescein angiography, and you can see leakage here. And just a simple laser, a focal laser will help this patient, not anti-VEGF, and you can give a good visual improvement to this patient.
AG, can we summarize?
Yeah.
Time is up here.
2 more slides, sir. And if you see here, this is a retinal tubule, and this does not require anti-VEGF because these are degenerative disease. Third thing is a choice of anti-VEGF. If you look into this patient has an polyp here, and if you look at OCT angio picture, these are BVMs, and this patient had an PCV, so it will not respond to ranibizumab. You have to go for a change of anti-VEGF, either Elia or Pagenex. So to conclude, anti-VEGF have revolutionized the management of retinal disorders, but there is a myth that it is a drug to treat all retinal problems. Where not to use this drug is highlighted in this presentation, and above all, should not ignore fluorescein angiography and adjunct treatment like laser photocoagulation in subset of our patient. Also important to stress that it requires multiple treatment sessions. Thank you very much for your kind attention.
Thank you, AG. For shortage of time, we will not have much discussion, but I'll just summarize in 5 lines. You see, plethora of anti-VEGF agents are available. Use them wisely. Diabetics Mallika taught us that the number of injections continue to reduce with time. And in ARMD, Dinesh said, do not stop, and there should be zero toleration to fluid. And Ashish said that biosimilars have actually filled the gap. Newer agents, believe me, are promising with respect to drying, duration, and also economics. And maybe they will rule over the first-line agents very shortly. And last talk, which was very important, was that all macular lesions do not require anti-VEGF agents. So with this, we'll conclude and thank the audience for their patient listening. Thank you.
Thank you, sir. Very good course. Thank you very much.